In this scenario, there are two individuals at the emergency department. The first one is 23-year-old Hannah, who reports lethargy, fatigue, reduced appetite, muscle weakness, and constipation. She also says that lately she gained a bit of weight and has a low libido. On clinical examination, she has periorbital edema, dry, cool skin, her nails are brittle, and her reflexes are slow. She also has a moderately enlarged, painless goiter. The other person is 33-year-old Quentin, who also presents with lethargy, fatigue, reduced appetite, muscle weakness, constipation, and he's also complaining about feeling cold all the time. He said that he recently had the flu, but no other illnesses. On clinical examination, there's periorbital edema, dry, cool skin, brittle nails and hair, and a very painful goiter. TSH, free T3, and free T4 are taken, along with antithyroid peroxidase and antithyroglobulin antibodies. Both Hannah and Quentin have high levels of TSH and low T3 and T4 levels, but Hannah has positive antithyroid peroxidase and antithyroglobulin antibodies. Both individuals seem to have hypothyroidism. Enjoying our Osmosis videos? Unlock your full potential with an Osmosis subscription. Get unlimited access to every Osmosis feature and resource with a free 7-day trial. First, a bit of physiology. Normally, the hypothalamus detects low serum levels of thyroid hormones and releases thyrotropin-releasing hormone, or TRH, into the hypophyseal portal system. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin or simply TSH. TSH stimulates the thyroid gland. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound, or free, in the blood, and this is the form that acts upon nearly every type of cell in the body. Once inside the cell, T4 is usually converted into T3, and it can exert its effect. T3 speeds up the cell's basal metabolic rate. It increases cardiac output, stimulates bone resorption, basically thinning out the bones, and activates the sympathetic nervous system. Thyroid hormones are also involved in a number of other things, like controlling sebaceous and sweat gland secretions, hair follicle growth, and regulating proteins and mucopolysaccharide synthesis by skin fibroblasts. Now, hypothyroidism can happen a few different ways, and all of them result in a decrease in thyroid hormones and a decreased basal metabolic rate, where cellular reactions are happening slower than normal. There are three types of hypothyroidism. In primary hypothyroidism, the thyroid gland is the problem because it isn't making enough thyroid hormones. Not only is there a lack of T3 and T4, which causes a slowing down of metabolic processes, but there are also increased levels of TSH from the pituitary to try to stimulate the gland. A secondary effect of the high levels of TSH is that it stimulates fibroblasts in the skin and soft tissues. The stimulated fibroblasts start depositing glycosaminoglycans in the interstitium. Secondary hypothyroidism is caused by damage to the pituitary, and tertiary hypothyroidism is caused by damage to the hypothalamus. These are sometimes called central hypothyroidism. A high-yield fact for your exam is that they can lead to a decrease in TSH release, which decreases the activity of the thyroid. Regardless of the cause, symptoms of hypothyroidism are the same, and in order to remember them better, keep in mind that hypothyroidism slows down almost everything. It can take years to manifest and affect multiple systems. Metabolic findings include modest weight gain and cold intolerance due to the low basal metabolic rate. Skin and hair findings include cool skin due to vasoconstriction and dry skin due to reduced secretion of the sweat glands and sebaceous glands. The hair is coarse and brittle, and there can be diffuse alopecia. Also, the nails are brittle. Hypothyroidism leads to an increase in glycosaminoglycans in the interstitium, which can elevate the osmotic pressure, leading to water retention and eventually non-pitting edema. As a result, the individual has a puffy appearance called myxedema. Ocular findings include periorbital edema. Gastrointestinal findings include constipation due to low GI motility, and there's also reduced appetite. Musculoskeletal findings include hypothyroid myopathy, which presents with muscle weakness, especially proximal weakness. Sometimes there can also be muscle damage, and in this case, CK levels are increased. It's not exactly understood why this happens, but it's known that thyroid hormones have a great influence on cell metabolism, and this includes muscle cell metabolism. Sometimes carpal tunnel syndrome can appear, and it's thought that this happens due to the accumulation of glycosaminoglycans. There can also be myoedema, which is a bump caused by local muscle contraction when triggered by light percussion with an object. The prolonged muscle contraction is a result of the alterations in muscle fibers caused by hypothyroidism. Reproductive findings can include menorrhagia and oligomenorrhea in those with a uterus, as well as low libido and even infertility in people of any sex. These changes can occur due to deficient LH secretion. Neuropsychiatric findings include hypoactivity, lethargy, fatigue, weakness, depressed mood, and slower reflexes. Finally, cardiovascular findings include bradycardia and dyspnea. Diagnosing hypothyroidism is done by measuring blood levels of TSH, free T4, and sometimes free T3. In all cases, thyroid hormones will be low, but TSH levels vary. If it's due to a primary cause, TSH will be high, and if it's due to a central cause, TSH will be either low or normal. There can also be hypercholesterolemia due to low LDL receptor expression. Okay, let's now start talking about causes of hypothyroidism, starting with causes of primary hypothyroidism. First, there's chronic autoimmune, or Hashimoto thyroiditis, which is the most common cause of primary hypothyroidism in countries that fortify foods with iodine. This is an autoimmune disorder where T cells and autoantibodies like antithyroid peroxidase and thyroglobulin antibodies infiltrate the thyroid. Remember these antibodies because this is very high yield. Now, there are several types of genes involved in the regulation of the immune response, including the human leukocyte antigen, or HLA system, and the cytotoxic T lymphocyte-associated antigen, or CTLA system. Interestingly, individuals with Hashimoto thyroiditis often have specific immune regulatory genes in common with each other. In addition, individuals with another autoimmune disorder are more likely to develop Hashimoto thyroiditis. Damage to some parts of the thyroid and the subsequent increase in TSH leads to thyroid hypertrophy and hyperplasia. In other words, the thyroid responds to autoimmune damage by increasing the size and number of healthy follicular cells, both of which causes the thyroid to enlarge. Unfortunately, this compensation is short-lived, and eventually, the autoantibodies cause so much follicular cell damage that they destroy thyroid function altogether. In the beginning, as the follicles rupture, they release a pretty high amount of thyroid hormones, resulting in an initial phase of hyperthyroidism. On histology, with Hashimoto thyroiditis, there can be Hurtla cells, which are also called oncocytes. These cells arise from the follicular epithelium, have an eosinophilic cytoplasm, and a vesicular nucleus with a large nucleolus. There can also be lymphoid aggregates with germinal centers. On clinical examination, there can be a goiter, which is an enlarged thyroid gland that doesn't cause pain. In individuals with Hashimoto thyroiditis, there's a higher risk for developing lymphoma. Moving on to subacute granulomatous thyroiditis, also called de Quervain thyroiditis, which is a self-limited condition that often follows a flu-like illness, such as a viral infection. What you must know for your tests is that this is an inflammatory condition where the follicular cells are damaged by inflammation. Its evolution typically has 3 phases. First, there can be hyperthyroidism due to the extra thyroid hormones released by the damaged follicles, followed by hypothyroidism, and then there's the return to normal thyroid function. On histology, in the early phases, there are neutrophils and destruction of follicles with colloid depletion. Later on, granulomas that surround the follicles can be seen. On clinical examination, there's jaw pain and the thyroid is very tender. Labs will show high ESR. Next, there's renal thyroiditis, which is a chronic inflammatory condition of the thyroid where the thyroid tissue is replaced by fibrous tissue with inflammatory infiltrate. Although the etiology of renal thyroiditis is unknown, it's thought that it's related to systemic conditions that affect immunoglobulin G4, such as autoimmune pancreatitis, retroperitoneal fibrosis, and non-infectious aortitis. Usually, 1/3 of individuals are hypothyroid. Fibrosis sometimes can extend to local structures, like the trachea and esophagus, and due to extension, it can sometimes be mistaken for anaplastic carcinoma. On the clinical examination, there's a fixed, hard, painless goiter. Next, there's postpartum thyroiditis, which is a self-limited thyroiditis that can happen up to 1 year after delivery. The exact cause isn't known, but it's considered to be autoimmune. It can have different clinical presentations, such as transient hyperthyroidism, hypothyroidism, or hyperthyroidism followed by hypothyroidism. On histology, there's a lymphocytic infiltrate with occasional germinal center formation. Next, we have congenital hypothyroidism, which affects newborns. It can be caused by antibody-mediated maternal hypothyroidism, which is when the maternal antibodies can destroy the newborn's thyroid. Other causes include thyroid agenesis, when the thyroid gland doesn't form at all, or thyroid dysgenesis, which is when the thyroid gland is abnormally formed. And this is also the most common cause of congenital hypothyroidism. Finally, it can be caused by iodine deficiency or by dyshormogenetic goiter, which is when there's a lack of enzymes for the synthesis of thyroid hormones. Remember that some of the mother's thyroid hormones are passed onto the baby, so symptoms will only manifest after these hormones are gone. These include the 6 Ps: pot-bellied, pale, puffy-faced, protruding umbilicus, protuberant tongue, and poor brain development. Finally, hypothyroidism can be caused by iodine deficiency. And this is common in countries that don't fortify food with iodine. Another cause of primary hypothyroidism is the Wolff-Chaikoff effect. This is an autoregulatory phenomenon that happens when there's too much iodine. With too much iodine, the thyroid responds by inhibiting the synthesis of thyroid hormones in order to avoid producing too many hormones. This doesn't last forever. Eventually, the thyroid will escape this effect and resume thyroid hormone production. Other causes include medications that decrease thyroid hormone synthesis, like amiodarone, lithium, and sulfonamides. Central hypothyroidism is far less common. Secondary is usually due to an anterior pituitary tumor, or an infarction that damages the gland and prevents TSH production. Tertiary hypothyroidism occurs when there's damage to the hypothalamus, and this can be due to trauma or a lesion that compresses the region, leading to decreased thyrotropin-releasing hormone production. Treatment for all types of hypothyroidism is a thyroid hormone replacement therapy, primarily using levothyroxine, a synthetic T4. Alright, as a quick recap, hypothyroidism can be primary when the thyroid gland is the problem, secondary where the pituitary gland is affected, or tertiary where the hypothalamus is damaged. Hypothyroidism can affect multiple systems, causing weight gain, cold intolerance, skin and hair findings, myxedema, periorbital edema, constipation, and myoedema. Potential reproductive findings include menorrhagia, oligomenorrhea, low libido, and infertility. Neuropsychiatric findings include hypoactivity, lethargy, fatigue, weakness, depressed mood, and slower reflexes. Finally, cardiovascular findings include bradycardia and dyspnea. Diagnosing hypothyroidism is done by measuring blood levels of TSH, free T4, and sometimes free T3. In all cases, thyroid hormones will be low, but TSH level is elevated in primary hypothyroidism. Primary causes of hypothyroidism include Hashimoto thyroiditis, subacute granulomatous thyroiditis, also called de Quervain, renal thyroiditis, postpartum thyroiditis, and congenital hypothyroidism, which affects the newborn. Other causes of primary hypothyroidism include iodine deficiency, Wolff-Chaikoff effect, and medications like lithium. Okay, back to our cases. Hannah came in with the classic symptoms and signs of hypothyroidism, like lethargy, fatigue, reduced appetite, muscle weakness, constipation, along with weight gain, low libido, periorbital edema, dry, cool skin, brittle nails, and slow reflexes. Lab tests confirmed primary hypothyroidism because they showed high levels of TSH, along with low levels of free T3 and free T4. She also has a moderately enlarged, painless goiter, and this, along with the positive antithyroid peroxidase and antithyroglobulin antibodies, leads to the diagnosis of Hashimoto thyroiditis. Quentin also presents with symptoms of hypothyroidism, which the labs confirm is primary in nature due to the elevated TSH. However, his goiter is very painful, and, along with his history of a viral infection, the likely diagnosis is subacute granulomatous thyroiditis. Helping current and future clinicians focus, learn, retain, and thrive. Learn more